on a case report of this patient who presented to us with small hands and smaller lens. Now, coming to the study, there's no financial interest involved. Coming to the introduction, the purpose of this case report was to report a case of Weil-Marchesani syndrome. So the clinical history, basically a 42-year-old female patient presented to our OPD with complaints of diminution of vision since 3 years, which was painless in nature, insidious in onset, and gradually progressive. And what was interesting about this case was that the patient also gave history of stiff joints in the hands and fingers, which is almost in the same duration, which was of 3 years. There was no history of any diplopia, flashes, or floaters. There was no history of any ocular trauma or previous ocular surgeries, no history of any photophobia, and patient is a known case of hypertension since 3 years. Now moving on to the ocular examination, in the right eye, the vision was counting fingers at half meter. There was no pinhole improvement. The rest, the lid and nexa, conjunctiva, and the cornea were within normal limits. The sclera was normal and the anterior chamber was of normal depth. The pupil was 3 mm, round and reactive. The lens showed senile immature cataract of grade nuclear sclerosis 1 with the inferotemporal subluxation of the lens. And in the left eye, the vision was counting fingers close to face. There was no pinhole improvement. Again, lids, adnexa, conjunctiva, and cornea and sclera were within normal limits. The anterior chamber was of normal depth. The pupil was 3 mm in size, and then the lens showed senile immature cataract of grade nuclear sclerosis 3 with inferotemporal subluxation of the lens. So both the eyes had inferotemporal subluxation. And the extraocular movements in the right eye were within normal limits, normal in all cases. The intraocular pressure, which was measured with Goldman's applanation tonometry, was 16 mm Hg. The gonioscopy showed angles of Schaffer's grade 2, so slightly narrow angles. The fundus examination in the right eye showed the disc having a cup disc ratio of 0.7, and there was also inferior and temporal thinning which was present, and the rest of the retinal examination was normal. And the Schirmer's test in the right eye showed 7 mm and T-BUT was 4 seconds. In the left eye, the extraocular movements were all normal in all the cases. The intraocular pressure was 18 mm Hg. Again, gonioscopy showed narrow angles with Schaffer's grade 2. The fundus again with similar findings of cup disc ratio of 0.7 with inferior and temporal thinning, and the peripheral retina was within normal limits. And the Schirmer's test was 6 mm and T-BUT showed dry eye with 3 seconds. Now these were the findings that we got. As you can see, in the right eye there was inferotemporal subluxation of the lens with NS1 grade, and in the left eye there was NS3 with inferotemporal subluxation. Now coming to the general physical examination, what was interesting to note was that this patient had short stature and she was of height of 4 feet 2 inches. She was moderately built and there was brachydactyly of the fingers and the toes. The rest of the general physical examination was normal. The systemic examination was within normal limits. Now these are the pictures. As you can see, the patient was of short stature. There's brachydactyly of the fingers and the toes. Now this is the right eye fundus examination. The left eye fundus, we could not take the image as the media was hazy due to cataract. Now moving on to the management that was considered for this patient, because of the general physical examination, we were considering a connective tissue disorder, but the blood workup showed that all the tests were within normal limits. What is to be noted is the serum homocysteine level was within normal limits. The cardiac echo was also normal, and chest X-ray and ECG were within normal limits. So we excluded the common differential diagnosis which we usually have with ectopia lentis, like Marfan syndrome, Ehlers-Danlos syndrome. There was Cruzon syndrome was also ruled out. So the patient was diagnosed with what could be possibly Weil-Marchesani syndrome, because these people present with brachydactyly and also with secondary glaucomas which was seen in this patient. There was also dry eye in this patient. So the patient was diagnosed as Weil-Marchesani, and patient was planned for lens extraction of both the eyes with anterior vitrectomy and iris claw implantation, and patient underwent these surgeries and the vision improved to 612 in the right eye on 2 weeks follow-up and 618 in the left eye. And the patient was also started on anti-glaucoma neuroprotective agent which was brimonidine, and the patient was referred to orthopedic management for the systemic management of pain and stiffness in the hands and the fingers that she had. So now discussion, although it is a very rare entity, Weil-Marchesani syndrome should be considered, as in this patient the cardiac findings were normal, but the only thing to be noted was the patient had short stature and short toes and short fingers. So a lot of times this can be missed out, so it should be kept in mind. Now the genetic counseling also can be done with autosomal dominant genes that has been studied in the previous studies being FBN1, and the autosomal recessive ones being ADAMTS and ADAMTS 1017 and LTBP2 genes. Thank you.
This case, corneal diameter.
So the corneal diameter was within normal limits.
Normal limits.
Yes. And there was no microspherophakia also in this patient, which was to be noted.
That's why you consider the other differential diagnosis.
Yes,
Otherwise, the
ma'am.
phenotype or the habitus is
Yes.
more in consistency with the Wilmer's disease.
Yes, ma'am.